Thank you very much, the organizers. Special thank you, Dr. Ravikant and Dr. Tulika, for making me a part of this. So, as we have heard from previous speakers, medical oncology point of view, we'll be starting with management of bladder cancer, muscle-invasive bladder cancer, and we are going to discuss the pros and cons of neoadjuvant, that is giving chemotherapy before operating, versus adjuvant, giving chemotherapy after surgery. What are the pros and cons of it? Which setting is better? Which setting is more opt? So to start with the premises, few facts which have been laid forward by my previous speakers, Dr. Swarnim and Dr. Manish, has been that radical cystectomy, that is a surgery with urinary diversion, is the preferred accepted standard of care for bladder cancer, for muscle-invasive bladder cancer. Neoadjuvant chemotherapy giving before cystectomy has been shown to improve overall survival. We are going to see that. And recently, just a previous presentation, we discussed tribodality therapy, in which maximum TURBT followed by radiation and concurrent chemotherapy is an accepted alternative for preserving the bladder and not letting the patient lose his urinary bladder. That is a starting premise. Now let us go to the workflow of how to select patients. So for patients who are having a muscle-invasive bladder cancer, whether stage 2 or stage 3, first important thing is the candidate fit enough to undergo a radical surgery, and is the patient acceptable to undergo a lifelong ileal conduit on his stomach. And so if the answer is yes, then you screen the patient whether this patient is eligible for chemotherapy. Chemotherapy here we means cisplatin, and for that it has to be, patient has to be a good performance status, that is ECOG performance status less than 2, good creatinine clearance more than 60, should not have significant neuropathy, no hearing loss significant, and should have a normal, reasonably normal cardiac function. NMIHA class 3 or class worse heart failure should not be there. These are the selection criteria for selecting your patients for neoadjuvant chemotherapy. And if the patient matches all these criteria, then we may offer him neoadjuvant chemotherapy before subjecting the patient for a radical cystectomy. Coming on to the benefit of neoadjuvant chemotherapy. So in the management of muscle-invasive bladder cancer, neoadjuvant chemotherapy has shown conclusively that it improves overall survival. So any modality in a cancer treatment, whether it is surgery, whether it is radiation, whether it is chemotherapy given before or after surgery, its efficacy is meant to decipher whether it improves the overall survival, whether the patients receiving that treatment is managing to live longer compared to patient not receiving that treatment. So here if you see, this is a forest plot which is a summary of the clinical trials which tend to answer this question, and on the left hand side the entire diamond is shifted. Both the wide interval of the diamond is entirely on the left hand side, suggestive of that this modality when used improves the patient overall survival and helps them stay longer. So these are the 11 clinical trials which had featured in the above meta-analysis, and if you see here in the middle column, most of the chemotherapy have included cisplatin, and most of them have been including a combination of cisplatin. So either methotrexate, vinblastine, doxorubicin, or doxorubicin cisplatin, or cisplatin gemcitabine combination has been used. Now, if you see the bottom part of the chart, the overall survival is 0.44, which is statistically significant. So these patients are managing to live longer, but with platinum-based combination, not a single-agent platinum, but a platinum in combination with either gemcitabine, which you are going to see, or combination of MVAC, methotrexate, vinblastine, or doxorubicin with cisplatin, which you are going to see. In the bottom one, it also improves the disease-free survival. Chances of the patient disease not coming back is also lesser in patient receiving combination chemotherapy before surgery. So in 1980s, from metastatic setting to locally advanced setting, people have been using a regime called as a MVAC. M stands for methotrexate, vinblastine, doxorubicin, and cisplatin. There's two MVAC. One is a classic MVAC, that is a dose-dense MVAC. So the classic MVAC has been the most routinely studied about 2 decades back. But the problem with MVAC is the side effects, because the dose as such that patients, more than half of them, develop significant neutropenia. Couple of them also develop mouth ulcers and gastrointestinal toxicities, including diarrhea. So a newer modified dose dense approach has been used. In dose dense, what we mean is that we give a higher amount of dose per unit time, which is a higher amount of dose per week is given to the patient, and we measure it with the standard and to see whether that higher dose is improving the response rates, it improves the disease survival, or at the higher dose, does it improve the overall survival as well? So this is a EORTC trial which tend to compare a classic versus a dose-dense MVAC schedule. Dose-dense is a newer one. If you see here, the red kind of column, the 2 and 2 which is mentioned on the right side is that in the dose-dense variety, we have a twice higher schedule, or twice higher doses of cisplatin and doxorubicin compared to a classic MVAC. Now, classic MVAC is given in day 1, day 8, and day 15, and but dose dense or high dose MVAC is given every 15 days with a GCSF support. Now, coming on to the important result, if you see here, the high dose MVAC or the dose dense MVAC produces a better complete response rates, which is about 21%, and a higher overall response rate 62%. And here, if you see the statistics, the difference in CR rates was about 0.09. So a dose dense regime of with GCSF produced a more CR complete response and more overall response rates, and which was statistically significant. Hence, saying dose dense improves the outcome. Now, second parameter apart from the response is to see the progression-free survival. Do the patient receiving this treatment progress lesser compared to those receiving the standard arm? So here also the dose dense regime, the progression-free survival was favoring the dose dense MVAC schedule. And a 7-year update of this trial also suggests the dose dense regime improves not only progression-free survival but overall survival as well. So now the classic MVAC has been dropped for majority of the guidelines, including NCCN, and now dose dense MVAC is one accepted type of treatment modality in a neoadjuvant setting. So let us go to the second question. If now dose dense happens to be the important standard modality, there is another parallel reasonably equally efficacious and less cumbersome to give for oncologist as well as patient friendly is a gemcitabine cisplatin. Gemcitabine is a single agent, is also very effective in bladder. These are the two protocols, dose dense MVAC and GemCis. You can see the doses here. I will not describe the doses. Gemcitabine is 1000 mg per meter square, cisplatin is 70 day 1, and gemcitabine is day 1, day 8. And on the left hand side, you can see the methotrexate, vinblastine, doxorubicin 33 and 30 mg per meter square, and cisplatin is 70 mg per meter square, given every 15 days with PEG GCSF support. Now, this trial compares whether dose dense newly accepted MVAC as compared to GemCis, which is more tolerable and easy on a friendly basis for the patient and the oncologist, comparing these two, where these two stand. So, the standard dose dense MVAC scores above GemCis in terms of response rates. So, standard methotrexate cisplatin combination produces a better complete response. It turns up that it causes more patients to go into non-muscle invasive bladder cancers. For example, patient is to begin with a muscle-invasive bladder cancer on TURBT. You subject them to chemotherapy, and after chemotherapy, when the surgery is done, the pathological report comes out that they now have non-invasive bladder cancer. That's also higher in MVAC, and disease confining to the bladder with perivascular involvement, that is T3. Those subset of patients after surgery and receiving MVAC chemotherapy to begin with also have a higher proportion of patients. So in short, this slide shows that using dose dense compared to GemCis leads to more understaging, more low staging of the tumor, down staging of the tumor compared to GemCis. But it comes at the cost. The cost here is side effects. The dose dense produces neutropenia, that is neutrophil percentage going down, leading the patient into febrile neutropenia, which is a kind of a life-threatening emergencies, is much higher in patients receiving MVAC combination chemotherapy. In fact, the nausea, vomiting and diarrhea is also worse in patients receiving MVAC chemotherapy compared to a GemCis chemotherapy. This is another trial called the Coexent trial, which is a prospective phase 2 trial, but this trial important is because it showed that pathological complete response is reasonably same if you give whether MVAC or whether you dose a GemCis, and progression-free survival and overall survival is also reasonably same if you use GemCis versus dose dense MVAC. Now the question is, in which select of patients would you use GemCis? Which subset of patients would you use a dose dense MVAC? So for a young fit patient who doesn't have any comorbidities, as we have just seen a couple of minutes back, even younger patients do present with muscle-invasive bladder cancer who has a normal renal function. So normal renal function are those patients, even if you have a moderate hydronephrosis because of tumor sitting on the top of the junction of the ureter and the bladder, you tend to put a stent over there, reduce the function, do URBT, and then you normalize the renal function, then you count the renal function whether it's normal or not. So those young fit patients, dose dense MVAC is appropriate regime. For patients who have a borderline performance status or who have comorbidities, they are hypertensive, diabetic, or who have a clearance less around 60, more than 60, or maybe between 50 to 60, those subset of patients, gemcitabine and cisplatin is preferably better because the patient tolerance improves and the reasonably outcomes are same in the two arms as we just seen the chemotherapy part. That is a neoadjuvant chemotherapy part, something which is to be given before surgery. Now we come to the adjuvant chemotherapy part, the treatment if surgery is done upfront for the patient, if the patient is referred to you by the surgical colleague and he has already done the surgery without giving neoadjuvant chemotherapy, then what are the options, when and how should we give the chemotherapy? So as we have seen neoadjuvant chemotherapy in the previous slides, it improves overall survival, it makes the patient 5% difference in absolute overall survival at 5 years, which is good numbers. But in adjuvant chemotherapy, it is not, the picture is not exactly black and white, it's more of a grayish region. So it has not been established, this role, adjuvant chemotherapy has not been exclusively established because of lack of fully accrued and adequately powered randomized clinical trial. And neoadjuvant, if you compared to adjuvant, still stands high because it has overall survival value, which adjuvant chemotherapy has not been able to provide conclusively till yet. Now, even if the patient who undergoes surgery, because surgery itself is quite morbid, 30% of them, because of slow recovery or because of complications, make them ineligible to receive adjuvant chemotherapy. That's also a thing which you need to keep in your mind. If you think कि surgery कर देते हैं उसके बाद में देखेंगे chemotherapy, so this is thing which you keep in mind. 30% of the patients might not actually be eligible to receive adjuvant chemotherapy because of slow recovery after surgery. So now patient selection for receiving adjuvant chemotherapy. So if there's no new adjuvant chemotherapy has been given and T3, T4 disease is there or node positive disease is there, then you go back and check whether the patient has cisplatin receiving eligibility criteria which we have just discussed before, whether this is good performance status, renal function is normal or not, no neuropathy, no hearing loss, cardiac function is okay. And if yes, he has three options. One is a classic MVAC which we discussed, which we no longer really use these days because of toxicity and because of better regimes such as dose dense MVAC which can be used, or a gemcitabine plus cisplatin based chemotherapy, which is a third option as we have just seen before. So regimes, as we have just discussed, there are three regimes which can be used in the adjuvant setting. Coming on to the data or coming on to the evidence which we have. So there is a systematic review and meta-analysis. There is a lot of criticism for this meta-analysis. I'll show you why. If you see in the lower part, the diamond is actually crossing the unity line. You see on the right hand side, its confidence interval is 0.59 to 1. So it does not actually improve the overall survival. It makes the diamond is predominantly on the left side, but it doesn't crosses the border of unity. So it doesn't improve the overall survival as per this meta-analysis. But it does manages to improve the disease survival. So patient receiving this kind of adjuvant chemotherapy, the disease chances coming back is lesser compared to those who don't receive this chemotherapy. And patients who having a node positive have definitely much more benefit than patients who complete to node negative disease. Now the problem with meta-analysis is that it includes heterogeneous patient. So patients even of T2, T1, sometimes with residual disease, not everyone undergoing perioperative was also included in the trial, in the meta-analysis. Poor accrual of majority of the trials, many of the trials had early termination. See, the problem with these doing clinical trials in bladder is that when you randomize them, the arm undergoing surgery, the patients as well as the clinician bias makes them not to undergo surgery frequently because they have a living ideal residual conduit. So that makes the trial accrual and early termination a high possibility. And this meta-analysis is unable to evaluate the benefit of based upon the tumor stage. And we have just seen it gives a benefit in nodal staging. If the node is positive, the benefit is more, but it doesn't give any idea or information whether the tumor stages, whether T4 has more benefit than T3 of receiving chemotherapy. Both have equal benefit, but none of them actually have any benefit with adjuvant chemotherapy. This is an important study, another URTC study, which compares whether after surgery, if you give chemotherapy, that is one option, and then you do chemotherapy when the disease comes back, the time of relapse. Because here the idea is to see whether the patient is living Similarly, in the two arms, whether the patient receiving now chemotherapy after surgery versus patient receiving then chemotherapy if the disease comes back, whether these two groups are likely to survive equal amount of time or not. This chart tried to answer this question. And if you see here also the diamond section by surgeons compared to the standard of the control arm. So if you take more notes of it, here yes or no picture. And for the entire presentation, I'll have to conclude muscle-invasive bladder cancer who elect radical cystectomy. Neoadjuvant chemotherapy prior to cystectomy is still accepted standard of care. Patients not previously treated with neoadjuvant chemotherapy and the high-risk disease, we still suggest them to undergo adjuvant chemotherapy. And high-risk features in this patient population includes the pathological T3 and T4 and those patients who have a node-positive disease. So that was my last slide. Thank you very much. And I hope I have completed in time.